Thank you, Chairpersons, and I would like to thank the organizing committee for giving me this opportunity. So today's my talk on role of antiplatelet therapy in primary prevention in patients with diabetes. So we know the diabetes is currently affecting over 400 million people worldwide, largely due to type 2 diabetes, representing a global pandemic. Cardiovascular disease, predominantly the coronary artery disease, is the primary cause for morbidity and mortality in patients with diabetes. A Danish population-based study done in around 3 million people showed that 5-year cardiovascular mortality in patients with diabetes who had no previous history of coronary artery disease is equal to a non-diabetic patient who had a history of ischemic heart disease previously. So multiple mechanisms contribute in patients with diabetes in the development of atherothrombosis. That is, they have accelerated atherothrombosis due to endothelial dysfunction and also metabolic disorders, including obesity, hyperglycemia, dyslipidemia, insulin resistance, and also increased risk of oxidative stress. The prothrombotic and the inflammatory state in patients with diabetes contribute to the accelerated progression of the atherothrombosis as well as the exacerbated risk on a patient who had a ruptured plaque. So the platelets in diabetes is said to be hyperreactive due to various mechanisms. It increased the platelet aggregation as well as the thrombosis formation in patients with diabetes. And also there are so many procoagulant factors other than the platelet, abnormal platelets in diabetes contribute to accelerated atherothrombosis in patients with diabetes. So when you consider the primary and secondary prevention, we usually aim to avert the onset of cardiovascular disease by targeting its natural causes and risk factors. But at a different level, in secondary prevention, if we consider, we include the strategies and therapies that address preclinical or clinical evidence of CVD prevention or progression. Both primary and secondary prevention of atherothrombosis involve the use of pharmacological agents that counteract the process of clot formation. So aspirin acts by irreversibly blocking the cyclooxygenase activity of the thromboxane A2 and prostacyclin generation. So in chronic administration, typically what we use in clinical practice, low dose 75 to 100 milligram clearly exceed the minimum dose required for platelet inhibition. Along with thromboxane pathway, it inhibit the induction of platelet aggregation and activation, which are the two main factors for thrombus formation and myocardial infarction. And also we could see the aspirin in low dose, even with the chronic administration, but through the prostacyclin pathway, when we give for a long time, it can counteract the protective way of gut protection by the prostacyclin may be inhibited, thereby increase the risk of upper GI bleeding. So the value of aspirin for a primary cardiovascular prevention is controversial because of the concern that increased bleeding may outweigh the modest benefit of the drug. But in contrast, secondary prevention is a setting where the benefit of aspirin have been repeatedly and convincingly demonstrated to outweigh the risk of bleeding. So aspirin as primary prevention trials, the ATT antithrombotic trialist collaboration published an individual patient level meta-analysis of the 6 large trials for aspirin as a primary prevention but in general population. These trials collectively enrolled over 95,000 people, including almost 4,000 with diabetes. Overall, they found that aspirin reduced the risk of serious vascular event by 12%. But the largest reduction was for the non-fatal MI, with little effect on the coronary artery disease death or the stroke. So the absolute risk reduction was markedly smaller in magnitude. So when you see the number needed to treat in these primary and secondary prevention trials, you have to treat 1,429 versus 67 to prevent one vascular event. After the ATT meta-analysis, there are newer trials but focus mostly on diabetes, but they also found the same effect. The largest trial, the Japanese Primary Prevention Project, they also still targeting asymptomatic patients. These all 4 studies included somewhat higher risk individuals than those who participated in the ATT. So none of the 4 trials provided conclusive evidence to support the routine use of aspirin for primary prevention in cardiovascular disease. In general, these meta-analyses reported a 10 to 13% relative reduction in combined serious cardiovascular event, driven by about 19 to 22 reduction in non-fatal MI and 13 to 14 reduction in ischemic stroke. The reduction in all-cause mortality was statistically significant in some meta-analyses, but it's really modest, like 5 to 6%. Conversely, in CLIPS trial, which was performed in patients with peripheral atherosclerosis but without a history of coronary artery disease, low-dose aspirin prevented serious vascular event compared with placebo, including in patients the subgroup with type 2 diabetes. When you consider risk of bleeding, the antithrombotic trial meta-analysis and subsequent meta-analysis incorporate the newer trials confirmed that aspirin increased the risk of bleeding by 33 to 43% for hemorrhagic stroke and 55 to 69% for major bleeding and 29 to 64% for the gastrointestinal bleeding. And also we have to note that the risk of bleeding in these trials are more in a patient who has high risk for developing cardiovascular event in next 10 years compared to low risk people. So the lack of statistical significance for these endpoints in diabetes meta-analysis is likely related to the low number of events, reflecting a power issue. But in these all studies, the risk of bleeding is numerically increased. So the trials may contain the participant which may not represent the true hazards of routine aspirin prescription in our day-to-day practice. Overall, regardless of the relative benefit of the aspirin, the absolute benefit appear in order of magnitude very small in primary trials than the secondary prevention trials. The ATT meta-analysis were population-based and did not specially focus for diabetes. Only 4,000 people are with diabetes. In the ATT meta-analysis, compared with subjects without diabetes, experienced a similar non-significant relative reduction, but little effect on stroke, so the no impact on mortality. Since the publication of ATT meta-analysis, the other meta-analysis we saw also addressed the primary cardiovascular prevention in diabetes showed only 10% reduction in the serious cardiovascular event and 16 and 14% non-significant reduction in MI and stroke, but there's twofold increase in significant GI bleeding. There are concerns in the heterogeneity and limitation of the primary prevention studies, including underpowering for sample size and differences in the study design and primary endpoints, risk profiles, and the high rate of aspirin discontinuation and the aspirin regime, and non-uniform reports of statin treatment prevalence in the study groups. Despite these bias, the less than expected clinical benefit of aspirin in patients with diabetes might be explained by the presence of multiple thrombotic pathways involved in the pathogenesis of cardiovascular event and also the altered platelet function, especially with poor glycemic control in patients with diabetes. Various aspirin formulations have been tested to attempt to improve the efficacy of or to limit the adverse effects of aspirin. Enteric-coated formulation increase the rate of low responsiveness and also reduce bioavailability. And the extended release aspirin shown to be improve the tolerability profile, but no extensive clinical data available to support routine prescription. So when you think about the dosing of aspirin, the average daily dose used in clinical trial was very much vast, from 50 to 650. But the general recommendation is to use the lowest possible dose, that is 75 to 100 milligram. There is a phenomena in diabetes called aspirin resistance, where the patients are not responding to the normal dose of aspirin. And also there are some studies examine whether the twice daily dosing of aspirin will improve the efficacy, but still these are under trial. So to consider altogether these facts, the latest guidelines from the American Diabetes Association recommend a risk-based approach with aspirin endorsed as primary prevention strategy in diabetic patients with a 10-year risk of cardiovascular event more than 10%. So they recommend aspirin therapy, the low dose 75 to 162, may be considered as a primary prevention strategy in those with type 1 or type 2 diabetes who are at increased risk of cardiovascular risk. That includes most of the men and women with diabetes aged 50 years who have at least one additional major risk factor, such as family history of premature atherosclerotic cardiovascular disease, hypertension, dyslipidemia, smoking, or albuminuria, and are not increased risk of bleeding. So if the patients have less than 10% of the cardiovascular risk or intermediate risk, say 5 to 10%, you have to have a clinical judgment. So the risk stratification is essential, therefore, to identify higher risk subjects who may derive the benefit from aspirin that offset the increased risk of bleeding. While risk calculators such as those from the American College of Cardiology and American Heart Association may be useful tool to estimate the 10-year risk of cardiovascular disease, we know in diabetes itself confers a high risk. So the risk calculators have limited utility in patients with diabetes. And there are some recommend the non-invasive investigations such as CT coronary angiography may be useful in patients as a primary prevention to see whom will benefit from the aspirin that outweigh the risk, but it's not for a routine practice, it's not recommended. In a patient with a low risk, say diabetic less than 50 years with no additional risk factors, aspirin use is not recommended. And also clinical judgment needed in a younger patient who had risk factor or the older patient who has no risk factor until further research available. And aspirin use around less than 20 years is generally not recommended due to the risk of race syndrome. So concomitant use of reversible COX-1 inhibitor such as ibuprofen and naproxen exert a competitive effect on irreversible acetylation of the platelets by aspirin. So this pharmacodynamic interaction does not occur in some NSAIDs which has COX-2 selectivity. So the general recommendation is to avoid COX-1 inhibitor. And in a patients who had a high risk of bleeding, like previous history of peptic ulcer disease, adding PPI, proton pump inhibitor, may be help to reduce the risk of bleeding. And because of the to increase the bioavailability, uncoated formulations should be used than coated formulation. So then we know the patients with type 2 diabetes have an increased risk of some types of cancer, particularly the colonic, colorectal, as well as the pancreatic. There are some long-term follow-up studies of aspirin in a primary prevention of cardiovascular disease showed that low-dose aspirin may protect or reduce the colorectal cancer incidence and mortality from 5 years onwards. So the recent trials published recently show the further evidence of aspirin as a primary prevention. The ARRIVE trial, aspirin to reduce the risk of initial vascular event, published in Lancet 2018, they randomized more than 12,000 European and US primary care patients from 55 to 65 years who had a moderate cardiovascular risk. And in fact, the event rate was very low in these studies. So the low number of expected event rate for the low risk patient did not show any difference. So the aspirin group, 100 milligram versus placebo, there was no reduction in the major cardiovascular event. And the second, the largest primary prevention trial was ASCENT trial. So they also randomly assigned 100 milligram aspirin to placebo, which was published August 2018. So the absolute benefit of aspirin in preventing serious cardiovascular event was counterbalanced by the increased extracranial bleeding. And it is a 7-year follow-up study. And also these ASCENT study, the number of malignancies in this population was high, but they didn't show any reduction in the aspirin group compared to the previous study. The Aspirin trial, published in NEJM, raised further doubt about the benefit of aspirin for primary prevention. This trial looked at use of 100 milligram of aspirin daily in people aged 70 old without heart disease or dementia or any disability, and found no survival benefit. In fact, the study found higher all-cause mortality in the group who took aspirin, but the death was mostly due to cancer. So when we consider alternative to aspirin, if there is intolerant to aspirin, we may consider clopidogrel. But dual antiplatelet therapy like clopidogrel and aspirin should not be used as a primary prevention. This is the Charisma trial. They showed a high bleeding risk in primary prevention trial when you give dual antiplatelet therapy. So in summary, the benefit of aspirin for patients with coronary vascular disease clearly exceeds the risk of bleeding, which makes the role of aspirin for secondary prevention undisputed. A modest benefit has been demonstrated in primary prevention, but the trade-off aspirin initiation versus increased risk of intracranial and gastrointestinal bleeding. So we have to use the lowest effective dose. The uncoated formulation use may be beneficial than the coated formulation, and concurrent administration of NSAID may increase the risk of bleeding and should be avoided whenever possible. And if there is a risk of high risk of GI bleeding, we have to use PPI to reduce the bleeding. So the mere presence of diabetes does not appear sufficient for aspirin to confer a benefit clearly exceeding the risk of bleeding.